Thank you. So I'd like to just say thank you very much for inviting us here today. Really, Charlotte and I really do appreciate this invite, because like your conversations before, what we are finding is that we're not reaching the groups, the same as with the vaccination groups that we want to reach. With this offer of treatment, we're not reaching out to all of the groups that we want to. So we're hoping that you may be a means for us to get this message that our service exists. And that's really the purpose of our talk today, as well as informing you about what long COVID is and the treatment offers. So I have to just say sorry, I'm trying to find a really quiet room, but every now and again there is some drilling happening above my head. So my apologies. So thank you for putting the slides up, Fran. So yeah, my name's Maggie Quinn, and I'm sure Charlotte will introduce herself at the end. And Charlotte is the Sheffield post-COVID programme manager. Next slide, thanks. So what I'm really keen on this next slide, we've just got the one signpost, and it's signposts to rehabilitation, and that's just to really let everyone know on this call today that we now have got a pathway for rehabilitation, and that feels really positive in itself.
Slide is talking about what is long or post-COVID syndrome, and I think quite a lot of people may have heard of this. It's been in the news quite a lot. This term sort of long COVID has been bantered around, and post-COVID. And here is just really the nice guidance definition in terms of when it's classified as that kind of long or post-COVID syndrome. And really that's from beyond sort of 12 weeks time is what the definition would be. Recognising that many people will get better by themselves with time, really, that symptoms can be prolonged and some will get better, or for a smaller proportion of people, roughly 5 to 10% of those that have suffered with COVID will go on to get this kind of long COVID syndrome, post-COVID syndrome. Next slide, please. So here you go, some stats there really in terms of symptom prevalence. So you can see here that quite a number of patients will be symptomatic for at least 4 weeks. And those numbers do decline, so it's less and less that will suffer with long COVID, but actually it's still quite a significant proportion of the population. A figure that I heard today was they're anticipating potentially up to 50,000 people in London alone may end up having long COVID. Next slide, please. So what are the symptoms? And again, I would reiterate that we're constantly learning. We talk about the analogy of building the plane as we fly, and we're learning about long COVID more and more with every passing week. But these are the predominant symptoms that are kind of regularly coming through. And I'd probably say the top symptoms that we're noticing patients complaining of is significant fatigue, and I'd say breathlessness as well, and reduced sort of exercise ability, deconditioning. I think are also significant symptoms that people are experiencing. But as you can see from this list of symptoms, it is what we would call sort of multifactorial. So it's affecting lots of parts of the body. It's not just breathing. It's not just your ability to exercise. It could be that you're not sleeping very well, that you're getting dizziness. Some people get joint pains or muscle aches that come and go. And some people even get sort of sickness, diarrhea, flu type symptoms with it. Next slide, please. And so what we did early on, and I think that was quite unique in Sheffield, is we brought together, or we tried to bring together professionals from across healthcare, so from primary and secondary care, and also supporting organisations and our community specialist clinicians to start to think about, well, how do we start to support patients who are suffering with this condition and the longer term effects of COVID. And paramount to our work was to ensure that we heard the voice of our patients. And so early on in our work stream, which started way back last year, sort of April, May time, quite early on in the disease history, we got patients involved, and we undertook interviews and focus groups with a range of patients to try and understand what their problems were. And it's from the back of their comments that we've developed the different pathways, which we'll go on to talk about. But the significant concern of patients, sort of when we did these interviews last year, was that they felt they didn't know who to contact, they weren't sure what information was available, yet they understood that as it was an emerging disease, this could sometimes be difficult to fathom. But they also felt like, what is the support? Once I've had my condition, who do I need to go to? And there was this theme of sort of a lack of communication between services. So these patients had lots of symptoms and therefore might have been referred to 2, 3, maybe more different supporting services, but they didn't seem to integrate with one another, talk to one another, and it felt very disjointed. Next slide, please. And so there's lots of things that patients can do if they think they're suffering from the longer term effects of COVID and perhaps the long COVID syndrome as we describe. And here's some useful resources. So the first one is Your COVID Recovery, and this is a national support tool that has lots of advice about the different symptoms that we've described and the things that patients can do in terms of self-management to try and help with those symptoms, help with their recovery. And then on the Sheffield Teaching Hospitals website, we've also developed a range of resources that patients can tap into. And for some patients, that might be enough, that they go away and use the self-management advice and in time may improve. Next slide, please. But what if symptoms persist? And as I've already mentioned about the patient voice group, we said that it was absolutely integral that healthcare was integrated, that we improved the communication, that we're informative for patients and we're supportive. And that's why, as I described, we brought together the different healthcare organisations and voluntary organisations from across Sheffield to start to work together to consider how we best support patients. Next slide, please. And so we've developed a pathway, and hopefully this diagram helps to explain the different tiers of that pathway. So as I've already described in tier 1, many patients will self-care and self-management using the resources. Some patients may need support from their GP, which is tier 2, or other clinicians that fall within that primary care network, so district nurses, for example, or specialist practice nurses. And then we describe tier 3, where we bring in the specialist rehabilitation services and supporting services. And then in some instances, and in less cases, some patients may need specialist management of their complication. And that's where we link back in with the speciality doctors within secondary care. Next slide, please. So how do you access these services? So we need to remember that COVID-19 actually can be very complex. There can be multiple symptoms. They also can be very similar to other conditions, and COVID can also exacerbate pre-existing conditions as well. So therefore, it's really important that in the first instance, we encourage our patients to go to their GP. And by seeing the GP, they'll do a holistic assessment of the patient's symptoms. So they'll look at the whole you, physically, mentally, and they'll arrange for tests and investigations, because what we want to make sure is we're not missing something other than COVID that perhaps has come about over time. And so they may be blood tests. Some patients may go for chest x-rays, for example. And then what the GP will do is they'll refer on to the appropriate services to support you in your recovery, but it will be very tailored according to what that holistic assessment and those tests show. Next slide, please. And here's some examples of where the GP may send you to, which I've already slightly described in the tiers. So for some patients with more complex symptoms and needing that specialist input, they may go to the speciality clinics. So that's in secondary care, for example, to see a respiratory consultant. They'd go through to the hospital, or they may be discussed in the speciality team meeting that runs every fortnight, which discusses more complex cases from across the city. We also, the GP might decide that primary care teams can support the patient, or even voluntary sector and other organisations. So examples of that is linking in with SOHAS, for example, for sort of employment advice. Or it might be that the GPs refer into the specialist multidisciplinary rehab assessment centre, whereby we have therapists, a psychologist and a doctor who can do a holistic assessment of the rehabilitation needs for the patients and will refer accordingly onto the supporting services. Or they may refer directly to mental health or psychology services, or directly through to a community rehabilitation service. Next slide, please. And so what we really want to reflect on is this is a journey for us all. And as I say, we're kind of building the plane as we fly, and we're learning more and more each and every week that we're seeing the patients coming through. And it's been very much a journey of integration. It's been a journey of keeping that patient voice at the heart of everything that we do, and trying to break down those cross-organisational boundaries, which perhaps historically have made that integrated approach slightly more difficult. Next slide, please. And there you can see there's the email address for Maggie. So obviously, if anyone has any further questions or would like any further follow-up, then obviously you can contact Maggie there. And I believe that might be the end of our slide set.